Our next speaker is going to be Dr. Michelle Sharp. She's in pulmonary and critical care medicine with Johns Hopkins School of Medicine. And she's going to be talking about treatment paths in sarcoidosis, what patients should know. So, Dr. Sharp, take it away.
Thank you so much. Can you all see my screen appropriately?
Yes, it's there. We can see it.
Perfect. It's such an honor to be here. I really appreciate the invitation. Um, and I will say this talk, I was trying to reflect on what patients should know. And I will say, I think you all can give me feedback because it's hard to think about exactly what you want to know. And so I put together some ideas on my end. Um, Here we go. So I wanted to review, and Dr. Culver just did an amazing overview of the animal models and the biology behind sarcoidosis. But I just wanted to go through a general overview again of what sarcoidosis is. It's characterized by non-caseating granulomatous inflammation, and I'm showing you a granuloma, which you've seen. One of the most important things is that sarcoidosis is not diagnosed by a biopsy. It is diagnosed by really three things that we look for. You want to have a compatible clinical presentation. In most cases, but actually you don't have to have a biopsy with the granulomas in it in all cases. But most cases you have a biopsy with a granuloma. And then we have to exclude everything else. And this is a mnemonic not to teach you all the things that we have to exclude, but really to show you that there are a lot of things that can cause granulomas. And because sarcoidosis is a diagnosis of exclusion, it can be very challenging. And you all have lived that experience. Patients in our practice and on my advisory or the Johns Hopkins Sarcoidosis Advisory Board have shared with me, having a decade of time between symptoms starting and getting their diagnosis. And so, because of the need to be a diagnosis of exclusion, it can be really challenging. And hopefully, some of the work that Dr. Culver shared will help us to get to the diagnosis quicker if we can have a blood test that can help identify patients with sarcoidosis. I'm bringing this up because I think that it is important when we think about treatment that sometimes we don't get everything right the first time. And so what I teach my fellows and my trainees and how I practice is that we approach a patient who we think has sarcoidosis and we think that we've appropriately ruled everything else out. And if they don't respond in the way that we would expect them to respond, we need to go back to the drawing board and we need to see, have we missed something? And so I think that's always an important concept to keep in mind when you think about sarcoidosis treatment. This is also one of my most favorite slides in all of my talks because it really demonstrates how broad sarcoidosis can impact individuals and that it is a systemic disease. So we're going to talk about treatment, but I think it's really important to think about treatment systemically. Um, and to know that not all sarcoidosis is the same, as you all have lived that experience. Think ways that sarcoidosis can affect you. It can affect you from your brain to your eyes, your heart, your lung, your bones, joints, kidneys. Very rarely in the GI system, but it can occur. The liver, the spleen, the muscles, and the skin. But you name it, sarcoidosis can affect that organ. And I think that is really important when we talk about treatment, because I truly believe that treatment has to include a multidisciplinary approach. I think care in sarcoidosis has to be done in a multidisciplinary way. And this is my multidisciplinary team that I am honored to get to work with every day here at Johns Hopkins. Um, we're actually taking a picture around Carol Johns, who established our program in 1962. We have one of the longest standing programs in the country, if not the world. And we pull all of the different organ groups together and we actually meet every Friday and we talk about cases and we talk about treatment strategies as a team depending on which organ is involved. And I really think that that is the most important approach or the best way to approach caring for patients with sarcoidosis. And we've been honored to be able to host national conferences to really, as a team, try to further this approach. So I also wanted to start or wanted to talk a little bit before I get into the nitty-gritty of treatment and really the challenges. And these are the challenges that you live with every day, and that patients with sarcoidosis develop symptoms, and sometimes the symptoms can be kind of vague symptoms. Sometimes they're more kind of concrete or specific symptoms, such as having heart block or the rhythm in your heart stops working, versus a cough or just feeling fatigued. And so it takes a varying amount of time to get from symptoms to diagnosis. You can get there in a month, or it can take you a decade or 2 decades. But that is challenging because we don't have good diagnostics right now. We don't have a great blood test. And then once you get from diagnosis to treatment and monitoring, that's a really big challenge, because what we're going to go over is that not all medicines work for every patient. And our medicines come with side effects. And so having a very good relationship and communication around treatment and monitoring is really important. And then we think about disease monitoring outcomes, which we're going to talk a little bit more about. That's also really hard because Dr. Culver and all of the experts can get together, and you could ask us all to tell you what the best outcome measure is for sarcoidosis. And that's really hard. Even in the lung, there's a lot of debate on what kind of test is the number one test to look at in sarcoidosis. And it's because it's not just one test that tells the story. And remember that whole person and all the different organs, that it's really specific for patients, and thinking about what the right monitoring plan is for each patient is really important. All right, so I think I've nailed this one, or I'm going to bring it home one more time, but one size doesn't fit all for treatment in sarcoidosis. And so there's an approach. And here is the guidelines from 2021 that was published with lead author of Dr. Boffman in the European Respiratory Journal. And I'm showing you this because I think it's important to think about quality of life and risk to organ function. And those are the two predominant tenets of how we approach treatment in sarcoidosis. How do you feel? And is there risk for permanent organ damage? Is there risk in your brain, in your eyes, in your heart, in your lungs? And that's really important, because if there's risk for permanent organ damage, then we tend to want to be a bit more aggressive in treatment. And then if there's not risk, it's really a discussion of how disabling are the symptoms, how hard are the symptoms, because the treatments that we have to offer right now come with side effects. And so it's balancing that symptom versus the side effect. And only you as a patient with sarcoidosis can make that choice of where your symptoms fall in terms of the organ, as long as there's not risk of organ damage. And so the way I'm gonna break it down on the next slide a little bit more, but these are listing a lot of the main medicines that we think about and use in sarcoidosis. So there's some change coming, and I think you've heard about that. But our guidelines still say that glucocorticoids or medicines like prednisone are the backbone of treatment in sarcoidosis. And I think it is important to note that they work in most patients with sarcoidosis. They're fast on. And so that what that means is that they can control the disease quickly, in 2 to 4 weeks. 2 to 6 weeks, you can get inflammation under control. But as I know you've talked about today, they come with significant risk and side effects. And so it's balancing the risk-benefit ratio of prednisone. Now, more and more, methotrexate, which is a medicine that you take once a week, you can take it by pill or an injection, has become more prominently thought about using in first-line therapy for pulmonary involvement of sarcoidosis. There's another medicine that there's been kind of retrospective head-to-head trials between methotrexate and azathioprine. It was a trial in Europe that showed that they're both probably good. Um, they both have different sorts of side effects, and so each of them patients may or may not be able to tolerate long term, but they're both very good, effective at controlling sarcoidosis in most cases. And then there's another medicine called mycophenolate or Cellcept or Myfortic that we use. My cardiology colleagues love this medicine because they're used to it in heart transplant. In pulmonary world, I would say we use it less often. And coming back to the multidisciplinary approach, one of the things that we've learned is each discipline tends to have a medicine they like better. And so I think really having more research to figure out what medicine is best if you have cardiac and pulmonary, if you have ocular and pulmonary. Is there a drug that is a best first-line therapy for different organ combinations? I will say methotrexate across heart, lung, and neuro or brain has been a really effective medicine. And so I do think that it is becoming the prominent kind of non-steroid medicine right now in treatment. It is important that you talk to your provider or clinicians about the risks and methotrexate. It's important that you don't drink alcohol with it because it can have toxicity and make sure that you're monitoring your blood counts with methotrexate, azathioprine, mycophenolate, all the non-prednisone medicines. You need to have regular blood work to make sure your liver is doing okay, your kidneys doing okay, and your blood counts are doing okay. When I start a new medicine that is not prednisone, we get labs every month for the first 3 months. And then if everything is stable, we do labs every 3 months after that. Um, and I think that is important to make sure, especially that your kidney, your liver, and your blood counts are okay with these medicines, which most of the time they are, but it requires monitoring. Other medicines, and Dr. Culver talked about this already a little bit, is adalimumab or infliximab. These are medicines that work on the TNF pathway, tumor necrosis factor pathway. Um, Adalimumab is an injection. It's a sub-Q, either weekly or every other week. And infliximab is an infusion. And there's actually a lot of debate right now on how that infusion is done, but typically you get 3 infusions within 6 weeks, and then you get an infusion every 4 to 8 weeks, depending on your disease activity and discussion with your team. Adalimumab and infliximab, it's important to get tested for tuberculosis or TB every year while you're on those because that is a specific infection that you're at risk for. And you always have to get tested for that before you start those medicines. Other things to think about with these medicines, since I brought up the tuberculosis, is it's also important to try to get your vaccinations done before you get started on these medicines, especially the biologics, to try to get you as protected as possible for your standard vaccinations. Although you can get vaccinated after you're on them, they're most effective if you get the vaccinations beforehand. And so we, as a routine in our program, check hepatitis vaccines or hepatitis status, and we ask our patients to get hepatitis B vaccination. We talk about the shingles vaccine, and we talk about pneumococcal vaccines or the pneumonia vaccines. These are additional treatment options that are more prime time than what Dr. Culver shared with you. Plaquenil or hydroxychloroquine is a really good medicine for joints and for skin involvement. It doesn't have as much effectiveness for pulmonary involvement long term, but it can actually really help with the cough in some cases for pulmonary involvement. Leflunomide is a cousin to methotrexate, and then topical treatments for cutaneous involvement. Tocilizumab, which is an IL-6 inhibitor, and it's used in giant cell arteritis. We've here actually at Hopkins published a case series on how that was an effective medication for patients who either couldn't tolerate infliximab or had it didn't work for their sarcoidosis. And we've had some good success in getting people off of steroids. Immunoglobulins or IVIG. So you talked about fatigue today. Small fiber neuropathy, which is a manifestation. If you think about my big picture of the person, I didn't actually have it's included in neuro, but it's a little bit different from neuro. We don't think of it in the same way as we think of the brain involvement. And it's hard because it doesn't always respond to the same treatments. And in fact, it usually doesn't. But IVIG is a pretty good treatment for the brain fog and the small fiber neuropathy. Now, I will say if you have systemic involvement, and so let's say your lungs are involved and your heart's involved, IVIG won't help with that. And so in those cases, we tend to try to use the TNF group, infliximab or adalimumab. And this is again why it's so important to have the multidisciplinary discussion and treatment plan to really think about which organs are involved and what's the best medication to target all the things that need to be targeted. Thalidomide and Cytoxan are not really used much anymore. I think we had one patient in our practice out of 2,500 that was on thalidomide, and I don't think we currently have anyone on Cytoxan. So I've talked about this already a little bit. I really truly believe that it's a shared decision making. And I think it is a conversation between you and your team because there's a lot of options. There's a lot of side effect potential, and every patient is different in what's important to them, what their comorbidities are, which means do you have diabetes? Do you have high blood pressure? What are your risk factors for side effects? And then also kind of what is most important to you in terms of targeting for treatment. And that brings me to my next slide, which is a monitoring plan. And I think whatever treatment you decide with your team, it is so important that you think about a monitoring plan. And one of my research dreams is to really put this into practice. Asthma has an asthma action plan, and I think sarcoidosis should have a sarcoidosis action plan, which empowers all of our patients to know these are the things I need you to look out for. These are the things I want you to call me for. Here are the side effects that you should be thinking about. And if you have them, call me because I probably can help you work through them, or we might have some ideas to help support that. And so I think any treatment plan you go on, I would empower you to ask, what are we looking for? What are the things that I need to watch out for? What are the kind of things I should call you for? And help build your own monitoring plan because often you see your team maybe every 3 months, every 6 months, and you really want to have the information and the knowledge of how you can protect yourself or kind of when to reach out, when not to reach out. Always, I'm happy to answer more questions about that one. I think the most important other thing that I can tell you is that treatment is more than medicines. And so I focused a lot on medicines, but in my practice, I talk to patients about activity. And I don't use the word exercise because I think that it's important to think about it as a prescription for me, like prednisone is. And there are some patients, because of their fatigue and their disease, that activity is 5 minutes of moving around. And we talk through this in my practice about kind of where you are. And it's important with activity, which I know you've heard today, that you don't run a marathon. I'm not asking people to run marathons. But because if you run a marathon, especially with the fatigue, you'll put yourself in that fatigue cycle. You never want to go too far, push too hard, which is hard because you're feeling better sometimes and you're like, yes, I'm going to go get everything on my list done. And you've got to pull back and not do that. But for the activity, especially with pulmonary involvement, if you do something consistently every day, And I have one patient who does a walk on his property every day, and there's a hill at the end of that walk. And that hill and how he feels is what helps us know, is his disease worsening? Is something changing? And if he holds the couch down and he doesn't move, then I can't tell that unless we get the lung function and we do the, CT imaging. But I want patients to feel empowered that you can listen to your body, and if we can come up with an activity that you can do that helps define whether you're worsening, how important that is for us as your team and also for you and your overall well-being. I think nutrition is also really important and something that we as healthcare providers are not always that great at. My research is actually moving into nutrition, and I have some really cool, exciting things coming to talk about that is not ready for prime time. But I think that what you eat matters and what you put in your body matters. I also am firmly someone who's never going to tell you you have to cut anything out. I have a sign over there that says cake is my happy place in my office. I really like cake, but I think it's thinking about things in moderation and trying to eat fresh vegetables, fresh fruit, or frozen over canned, thinking about trying to remove processed food from your diet as much as possible. And then kind of putting that kind of on the side of nutrition. And I think we have so much more work to do, especially with other diseases and even lung diseases out there, about how we could potentially support um, patients and minimize inflammation by nutrition as part of our treatment plans. I also think that sleep is really important and something that I talk to patients about. Sleep makes the world go round. And really thinking about your sleep habits, getting as much sleep as you can, getting screened for sleep apnea, which can really impact fatigue and overall well-being, and trying to think about your sleep as a sacred time, trying not to have a TV on, trying not to look at your phones. Um, which is hard, and I acknowledge and can relate to, but really getting as much good sleep as you can will help your overall well-being. And trying to think of, there was one more thing I wanted to say, and it just went out of my head. But so we talked about activity and movement, we talked about nutrition, and then we talked about sleep. Oh, stress. Um, I firmly believe, and I don't have any data yet to share this, but that stress and high stress situations can impact sarcoidosis, inflammation. And I have had patients who've come in from acute stressful events in their lives have really decompensation in their sarcoidosis, despite not changing their medicines. They're staying on everything. And so I think as much as you can do, we had an amazing talk earlier that I thought was very meaningful for me and everyone, and how to try to manage and improve your overall well-being. And if there are things in your life that you can do to minimize stress, I think that's really important. And if there are ways that you think your team can help you by minimizing stress, I think that's also really important. And with that, I think knowledge is power and is the most important thing in your care. And I'm so grateful to be here. I wanted to share a little shout out that we're going to be doing our third annual Say Sarcoidosis Patient Education event. It's completely free and online. And if you're interested, that's a QR code to check out. And you can look at saysarcoidosis.org to register. And with that, thank you so much for having me.
Well, thank you so much, Dr. Sharp. We appreciate all the great information. I tell you what, you need a pronunciation guide for all those different medications and everything. It's it's a lot. But there are a couple of questions in the Q&A. Is there a patient guide for questions to ask that would help us to develop our own monitoring plan? My doctor prescribed prednisone without any monitoring suggestions, so not good. So what would you suggest?
That's an awesome question. Um, that's actually something I'm working on. I'm not ready to go prime time. I will say our patient advisory board, if you look at saysarcoidosis.org, they put together patient-to-patient tips for starting prednisone. and listed a lot of different side effects that they have experienced and tips about how to approach that. I think from a monitoring plan, the most important thing is how your sarcoidosis is presented and trying to be very intentional about listening to your body. Although I acknowledge that sometimes you don't want to be over analytical of your body because then that stresses you and so it's a balance, and I think talking through that with your team is really important because there's some patients where I say, please don't keep a diary because a diary is actually going to cause you more stress and more anxiety. And I don't want that. I don't want you to focus on it. I want you to live your life and try to have as much of a meaningful experience in life as you can without worrying. I'm really good at worrying, by the way. So I tell them to let me worry. I'll do the worrying. Um, and so I think the best question, while I'm still trying to develop my kind of guide for patients to help support them in a self-management program, would be, what are the things that I should call you for? What are the things that you think I might experience with this medicine from a side effect? I think if you answer those two questions or ask those two questions and they give you a great answer, that you're set up for success, at least to start that process.
Okay. Another question. How is risk defined for knowing if permanent organ damage is in the foreseeable future?
Um, so that's a great question. I think it depends on the organ. I will say I tolerate very little inflammation for the brain and the eyes. Each organ is a little bit more forgiving. The brain and the eyes are not forgiving. And if you let spinal cord inflammation or brain inflammation go without being aggressively treated, you can have permanent damage even when I treat you. Like the scar's there, and that can be disabling and really impactful to your life. So I don't tolerate inflammation in that way. Now, there are patients who have pulmonary inflammation, and their inflammation, I can see it on the CT scan or even a PET scan, but they're pretty active and they're not having problems, and their lung function's pretty okay. And that's the patient where I say, if we let this go for a decade, and it doesn't get better and it gets worse on its own because we didn't talk about that. Half the people with sarcoidosis will get better on their own, right? And so we don't, it doesn't matter what we do, it's going to go away. And we don't want to give you lots of medicines if that's who you are. And so I think it's having a conversation in that standpoint of, how's your lung function doing and how are your symptoms and what is your activity, and can you keep that activity level up for me or increase it if we need to? And then that's where you do a monitoring program. And if you're seeing that there's more scarring on the CT scan or your lung function's dropping, then I think you're at risk, not this decade necessarily or next decade, but in a couple of decades of having scarring that then I can't reverse and having limiting lung function. And so the lungs, you can tolerate losing 20% of your lung function and probably still be okay. But if you get down to 40 to 50% of your lung function over 2 to 3 decades, that's when you might need oxygen. That's when you might need, to talk about kind of a lung transplant, and that's not what we want, right? We want to avoid that. And if you treat the inflammation before it gets to that far or that kind of situation, we can prevent it. If we do our jobs right and we use the medicines and we find the right cocktail of medicines to support you with, you should live a long, healthy life. And you should be able to do whatever you want to do. It's just all about figuring out where the inflammation is, what kind of long term, is it getting better, is it getting worse, and then a game plan to combat it.
Okay. Can you take methotrexate with infliximab to treat cardiac sarcoidosis?
Oh, I'm so thankful for that question because one of the things I didn't mention with infliximab, and I know Dr. Culver mentioned a little bit, is that you can build antibodies against it. So your body can actually build antibodies to attack the infliximab, and then it doesn't work anymore. And you can actually have kind of a bad reaction when you get the medicine. So we often use low dose methotrexate to try to prevent you from building those antibodies, to say, all right, body quiet down and tolerate the medicine so it can do what it needs to do. Infliximab and Humira or adalimumab are both medicines that you can build antibodies against.
How can you tell if you have heart or brain inflammation?
Um, Good question. I'm going to tell you what I usually do when I teach to the trainees. So, heart, the two big things that I worry about are bad rhythms and the heart not pumping well. So, bad rhythms can look like where you feel like your heart's racing or skipping beats. If you pass out with sarcoidosis, every patient in my practice knows if you pass out, that's a phone call. That's not a my chart message. That's not, I'll tell you next time we see each other. If you pass out, that's a huge red flag for a bad rhythm. And you need to get in contact with a healthcare provider or clinician and talk through that. Now, I unfortunately have the propensity to pass out if I get dehydrated. And so not every time you pass out has to be from sarcoidosis, but it's a highly concerning kind of possibility of a bad rhythm. For a heart failure, your heart not pumping well, you can get lower extremity edema. You can get short of breath when you lay flat, which is something I ask every patient when I see them. Um, for neuro involvement, so headaches, and neuro can be hard because it can be, vague symptoms and there's a lot of reasons to have headaches, right? Having headaches does not mean you have neurosarcoidosis, but headaches can be a concern. And what I ask patients to do is to keep a diary, how often they're coming, what's making them worse, anything else associated with the headache. Do you have sinus pressure? Is it worse in the morning? Is it something that you gain over the day as you start to fatigue? Your eyes hurt. Um, Other things that you can have is that you can actually look like you have a stroke. And so it can affect one of your peripheral nerves in your face that makes your face paralyzed. You can have vertigo and hearing loss. And I think that's the one that people miss sometimes for neuro involvement. And so if you acutely wake up and lose hearing in one ear, that's a phone call. That's not a wait around. We got to talk about it. Um, and then the vertigo is where the room's spinning. And so the room spinning can also be suggestive of cranial nerve 8 involvement in sarcoidosis.
Okay, what if you live in a rural area without access to many specialists? What would be the best approach to handle multi-systemic sarcoidosis treatment?
Um, I'm working on that. That's the other part that my research is working on because I do acknowledge that there are not enough good centers across the country, and patients have to travel great distances to get that multidisciplinary approach. I think you have a couple of options. If you have the means, could do a one-time consult to one of those centers or the closest center to get expertise, and then have that center connect with your home team. And so you have that the home team learns, right, from the multidisciplinary approach. And then you've also got a connection if you need it, maybe once a year, once every 2 years. Um, I think that is a huge problem. I'm hoping that we can grow access in the United States, but acknowledge that not having a good center close by or having to drive a couple hundred miles is really challenging. And so I would say until you can do that, keep doing things like this, and trying to gain as much knowledge as you can. And actually, one of the members of my patient advisory board gets very frustrated. He's like, Dr. Sharp, you're all about helping empower us to have knowledge, but can you teach the doctors too? And I tell you, I promise I'm teaching the doctors too, but I think there's so much work that needs to be done to help educate the healthcare field about sarcoidosis and its importance.
Yeah, you hear that a lot from patients about being misdiagnosed for, extended periods of time and
Yeah.
because the doctors are just not familiar with it. They're just not current.
Yeah.
Um, do you see much soft tissue sarcoidosis?
So soft tissue, do you mean subcutaneous maybe?
Well,
Or
all it,
muscle?
yeah, they didn't
Um,
say.
okay, so subcutaneous, yes, you can get these painful nodules that are under the skin. on your arms. I've seen patients get them on their sides. That can be really, really painful. Um, and I think that I think muscle involvement is really under recognized. And I'm very fortunate that I have a junior faculty member in our program, Kristen Mathias, who's a rheumatologist, who's really thinking about this much more. But if you look at that little man that I had up, or little person, the muscle involvement can be 30 to 40%. And I don't think we recognize it. I think our patients inappropriately get diagnosed with fibromyalgia when it's sarcoidosis related. And so I think if you're having subcutaneous symptoms, I would encourage you to try to keep a diary of them. See if when you go on a treatment, if things get better and things get worse. And that can be really helpful for your team because sarcoidosis can do so many things, but you're, as I tell my patients, entitled to normal people disease. And so it doesn't always have to be sarcoidosis. Figuring out what responds when you go on treatment and what doesn't can be very informative of should we be thinking about something else.
Gotcha. Okay, one last question. This person says they developed multi-symptom sarcoidosis shortly after COVID infection. They thought they had long COVID. Could COVID have been a trigger?
So that's a great question. And we have seen more sarcoidosis after the pandemic and within the pandemic. I don't know for sure if COVID could be the trigger, but what I will say is that COVID is extremely immunogenic. Um, what I mean by that is that it really stimulates the immune system, like it revs up your immune system. And so the way I've thought about it scientifically is you probably had sarcoidosis there that was smoldering and quiet. And then the COVID infection kind of sent it off to the races. And we've seen that in our practice. And I have one patient who I mentioned about the stress, but was completely controlled. We were doing well. And then she got COVID and we like lost complete control of everything and the kind of wheels came off. And so I don't know that we'll ever be able to tell you for sure was that your trigger. It's not a trigger that we've thought about. We've thought about mold. And there's some evidence for mold being a trigger, mycobacterium, which is like tuberculosis or the cousins or to tuberculosis, the bacteria in your skin. There's the first responders to 9/11 had a higher prevalence. And so there's probably something in that dust plume that they were exposed to, which had 400 different things. And so, as Dr. Culver said, I firmly agree that there's more than one trigger, and it's going to be really hard for us to tell you what your trigger is. More so, I think it's figuring out how to flip the switch back to normal, right? Because what the trigger does, the granuloma is your body trying to get around and protect you for whatever trigger started. And the trigger lights a match is what I tell my patients, and your immune system set off a 4-fire alarm. About half the people can switch their immune system back to normal. The other half go on to have the inflammation. I think the real and breakthrough will be figuring out how to flip your immune system back to normal, regardless of the trigger.
Gotcha. Well, thank you so much, Dr. Sharp. You have given us a lot to think about, and a lot of information, and we can't wait for the not ready for prime time information to reach prime time to to come out to see what's coming up in the future. So thank you so much. We appreciate your help with this.
Absolutely. I'm so honored to be here. Thank you.
Thank